Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. Today's video is about Piriformis syndrome. I know all of you have heard about Piriformis syndrome, and it seems that Piriformis syndrome creates some complication in the treatment for many doctors, and the first difficulty arises in properly diagnosing and establishing the condition of Piriformis syndrome. So I'd like to briefly go over some of the anatomy and clinical concerns involved with the assessment of what we refer to as Piriformis syndrome. And there's two basic anatomic considerations that we need to be aware of with regards to Piriformis syndrome. So first, let's talk about the anatomy of the sciatic nerve as it passes in and around the piriformis muscle, and then secondarily, let's talk about the anatomy of the piriformis muscle and relate those two anatomies to the various different forms of interactions that the sciatic nerve can take with the piriformis muscle as these two structures pass in and around each other. So let's begin with, first of all, the anatomy of the sciatic nerve. Now, remember that the sciatic nerve is actually not a nerve in and of itself. It's actually two nerves. The sciatic nerve is what we call the conjoined and confluence of the common peroneal nerve and the tibial nerve. And those two separate individual nerves, the common peroneal nerve and the tibial nerve, become invested in the same connective tissue fascia. And we call this connective tissue fascia the epineurium. And the epineurium, if we trace the epineurium back up into the spine, the epineurium becomes continuous with the dura of the spinal cord. So we have these two nerves. We have the common peroneal nerve and we have the tibial nerve. Now remember that the spinal nerve roots of the lumbar and sacral spine come off the lumbar and sacral spine high up in the lumbar spine, because the spinal cord itself ends at around the L1 to L2 level of the spinal column. So these nerve roots come off of the lumbar and sacral spinal cord, and as they do, they immediately divide, and they divide into dorsal primary rami and anterior primary rami. And the dorsal primary rami go on to innervate the lumbar paraspinal muscle. So we can discontinue our consideration of the dorsal primary rami at that point. The anterior primary rami then immediately divide. And the anterior primary rami of L4, L5, S1, and S2 all divide to give us both anterior and posterior divisions. Okay, did you get that? Each of the anterior primary rami of L4, L5, S1, and S2 go on to give us anterior and posterior divisions. Now, the posterior divisions of L4, L5, S1, and S2 combine to give us the common peroneal nerve. So remember that the common peroneal nerve is formed by the posterior divisions. The anterior divisions of L4, L5, S1, and S2, and also a slip from S3, and it's important to remember that S3 only has an anterior division. It does not have a posterior division. So those five nerve roots, those five anterior divisions, join and give us the tibial nerve. So we have the common peroneal nerve, and then we have the tibial nerve. The common peroneal nerve comes from the posterior divisions. The tibial nerve comes from the anterior divisions. Now, these two separate nerves then join to give us the sciatic nerve. And where they join and where they become invested in the same connective tissue fascia can vary. They can join early and become invested in the same connective tissue fascia high up relatively in the sacrospinal region. They can join relatively lower in the sacrospinal region, and anomalous configurations exist. So that's important to note, because as we're going to see, where they join together and become connected can influence the presence or absence of piriformis syndrome. And the piriformis muscle passes behind these three structures: the common peroneal nerve, the tibial nerve, and or the sciatic nerve. And depending upon where they join, the piriformis muscle can either overlay the sciatic nerve, can underlie the sciatic nerve, or the piriformis muscle can pierce through the common peroneal portion and the tibial portion of the sciatic nerve if they have not yet conjoined into the same connective tissue fascia. So various different configurations exist, and we'll talk a little bit more about that in a minute. So we have this structure that we call the sciatic nerve, and it's composed of two separate and distinct nerves: the common peroneal and the tibial. Now, as the sciatic nerve descends down the leg, the tibial and the common peroneal assume positions relative to each other. The tibial portion of the nerve lies lateral within the sciatic nerve. So if we're talking about my right lower extremity, the common peroneal portion of the nerve lies more lateral. The tibial lies medial, and it travels down the sciatic nerve in the posterior thigh in this relationship. Now, immediately behind the popliteal fossa, these two nerves then separate out from the connective tissue fascia, and they go their separate ways into the lower extremities. So we can probably suspend our discussion of what happens to those nerves as they pass into the lower leg right here for just a moment. But back up into the thigh, the common peroneal, which is traveling laterally, travels laterally down into the lateral aspect of the popliteal fossa, gives off one motor branch to the short head of the biceps femoris muscle. The tibial, as it passes medially down the posterior thigh, gives off several motor branches. It gives off a motor branch to the long head of the biceps femoris, gives off a motor branch to the semitendinosus, a branch to the semimembranosus, and gives off a small slip to the adductor longus muscle, which it sort of co-innervates in conjunction with the obturator nerve. So these are important muscle innervations to remember when it comes time to do your physical examination for the assessment of piriformis syndrome. Okay, so that's the anatomy of the common peroneal, the tibial, and the sciatic nerve, at least to the depth that we need to consider for now. So let's talk about the piriformis muscle. So the piriformis muscle is a pear-shaped muscle. That's what the name refers to. It's a pear-shaped muscle. And the piriformis muscle, if we consider my right hemipelvis, okay, from one half of the sacrum and this half of my pelvis, the piriformis muscle, if this is the anterior surface of my sacrum bone here, the piriformis muscle originates below and between the first and second sacral foramina. It originates between the first and second sacral foramina, and then has another slip that originates below the second sacral foramina, and a third slip, muscular digitations they're called, that insert on the anterior aspect of the sacrum. Okay? Now, in addition to this bony attachment on the anterior aspect of the sacrum, the piriformis muscle also attaches on the superior portion of the greater sciatic foramen, and also can have an attachment here. If we look at its posterior surface, can have an attachment on the capsule of the sacroiliac joint. So it has this multiple origination point in and around the anterior surface of the sacrum. And various anomalous originations can exist. So after it originates on the sacrum, it then progresses laterally, and it leaves the pelvis by way of the greater sciatic foramen, which it mostly fills by virtue of its volume, mostly fills the greater sciatic foramen, and then goes out to attach on the posterior aspect of the greater trochanter, where it shares a common tendinous insertion with the superior and inferior gemelli, and also the obturator internus. And so there's this sort of this confluence of tendinous insertions on the posterior aspect of the greater trochanter. And so the piriformis, by virtue of its attachment on the posterior aspect of the greater trochanter, is a lateral rotator of the hip. It's one of the 6 lateral rotators of the hip. And just as there can be anomalous anatomic configurations of the origin of the piriformis muscle, there can also be anomalous configurations of the insertion of the piriformis muscle as well. And some anatomy textbooks talk about the piriformis muscle not inserting at all onto the greater trochanter, but instead inserting onto the posterior aspect of the posterior hip joint capsule. So these are some important considerations, and it explains the frequency with which we see these piriformis syndromes, both in our clinical practice, and then for those of you that are qualified medical evaluators, also in your evaluating practice. Okay, so we have anomalous possibilities, anomalous configuration possibilities with the sciatic nerve. We have anomalous configuration possibilities also with the piriformis muscle. So let's talk about some of these configurations that exist that contribute to piriformis syndrome. Now, the piriformis muscle is innervated itself by what is known as the nerve to the piriformis. Now, anatomy references differ, and different references will cite different innervations and contributions to the nerve to the piriformis. All textbooks agree that the nerve to the piriformis is served at least by the S2 nerve root. Other anatomy references say that at least it's served by S1 and S2. And then other anatomy references and resources say that the nerve to the piriformis is actually formed through the contribution of L5, S1, and S2 nerve roots. So for our purposes, let's assume that the piriformis muscle is served by any 2 of those nerve roots. Let's pick S1 and S2. Now, the fact that that muscle is served by more than one nerve root, what does that tell us? Well, if you go all the way back to embryology, remember that the nerve roots innervate the myotomes. And the myotomes come from the embryologic somite. And the somite, as you remember, gives us the dermatomes, the myotomes, and the sclerotomes. And you'll remember that the somites were segmented. That's why we get the segmentation of the spinal cord, and all these nerve roots come off the C5 segment and the C6 segment, and here we are at the L5 segment, the S1 segment, and the S2 segment. So myotomes come from the segmented somites, and these cells, these precursor embryonic muscle progenitor cells, combine to contribute to a named muscle. Okay, so the piriformis muscle receives embryonic muscle cells from the segmented level of L5, S1, and S2, and we agreed that we're going to consider S1 and S2. So that explains why that sometimes there are divisions or septa or fascial divisions that create two heads of the piriformis muscle. We have a superior head and an inferior head, and possibly we could have three heads if we agree that the piriformis muscle is innervated by three nerve roots. So sometimes the piriformis muscle itself becomes divided at the delineation between the S1 myotomes and the S2 myotomes. And there's a fascial separation there, and the muscle is actually divided. Now, usually the muscle is not divided, it's an undivided muscle, but sometimes it's divided. So if we consider that we could have either an undivided muscle or a divided muscle, and we could have either conjoined tibial and common peroneal nerves, or we could have unconjoined tibial and common peroneal nerves. When we put all those possible combinations together, it gives us many different possible combinations and configurations of these nerve and muscle structures. So for example, the most common configuration of the piriformis muscle in relation to the sciatic nerve is that the sciatic nerve passes behind and underneath the piriformis muscle. That's the most common situation. Approximately 71% of cadaver dissections show that the sciatic nerve, which is the conjoined tibial and common peroneal nerve, passes behind an undivided piriformis muscle. Now, in the case of a divided piriformis muscle, we see that at least three possibilities exist. An undivided sciatic nerve can continue to pass underneath the muscle, even though the muscle is divided. The sciatic nerve can travel in front of a divided piriformis muscle, or the sciatic nerve can pierce a divided piriformis muscle. Several possibilities there. If we consider the fact that the piriformis muscle is divided and the sciatic nerve is divided, what kind of possible configurations could we have? Well, this would be the tibial portion. This would be the common peroneal portion. Remember, the common peroneal portion travels laterally because it comes from the posterior divisions. Those travel laterally in this sciatic nerve. So if we have a divided piriformis muscle and the nerves are still undivided, what are some configurations that we could have? Well, we could have the tibial nerve pass on top of the piriformis muscle and the common peroneal nerve pierce the muscle. We could have the tibial nerve pass in front of the muscle and the common peroneal nerve pass under the muscle. We could have the tibial nerve pierce the muscle and the common peroneal pass under the muscle. And all these different possible configurations, of which there's really no way to know unless you dissect the specimen, or unless you perform an autopsy and found out what is actually the configuration. Now, people don't usually die from piriformis syndrome, so you have to make your best assessment of the possible configuration by way of your findings on physical examination. We'll talk about those in just a minute. So all different types of configurations exist. So we can see situations where the nerve is divided over an undivided muscle, the nerve is divided through a divided muscle, a divided nerve passes normally through a divided muscle, and there's all different types of situations. Now, regardless of the type of configuration that anatomically exists, Persons with piriformis syndrome are going to present with a distinct cluster of clinical symptoms. They're going to have deep aching pain deep in the buttock muscle. And this deep in the buttocks in the region of the posterior hip and in the region of the piriformis muscle. Now this is different than the lower back and buttock pain associated with a disc herniation, because this piriformis distribution of pain will be unaffected by movements that involve or incorporate the lumbar spine. It's an extraspinal peripheral nerve entrapment condition. It's not a nerve root injury that we see, for example, with disc lesions. So these examinees will have pain in the buttock, pain in the posterior hip, and they will generally have neurologic symptoms related to entrapment of the common peroneal portion of the sciatic nerve. And some studies indicate that the common peroneal nerve is affected up to 6 times more frequently than is the tibial nerve because of its location and its posterior and lateral orientation in relationship to the tibial nerve. Renders it more susceptible to entrapment. So in the case of entrapment of the common peroneal portion of the sciatic nerve, the examinee is going to present with neurologic symptoms directly related to the common peroneal nerve. So this type of person, in addition to having symptoms of pain in the buttocks and in the posterior hip region, and pain down the posterior aspect of the thigh region, they're going to show some weakness on the short head of the bicep muscle to manual muscle testing. And they're going to show diminished lateral hamstring reflexes. Now let's talk about the lateral hamstring reflexes for just a minute. I know many doctors do not test the hamstring reflexes. With regards to the lower extremity, most doctors will test, of course, the patellar reflexes and will test the Achilles reflexes. But many doctors don't know or just simply do not test the hamstring reflexes. And the hamstring reflexes are really the only clinically relevant reflexes that we have for the assessment of the L5 nerve root. Now, we have both lateral and medial hamstring reflexes, and both of those reflexes are indicators of function of the L5 nerve root. Now, an interesting clinical distinction exists in that the lateral hamstring reflexes reflect the function of the L5 nerve root as it travels in the common peroneal nerve. And the medial hamstring reflexes reflect the function also of the L5 nerve root, but now as the L5 nerve root travels in the tibial nerve. So the medial and lateral hamstring reflexes, while they're both L5 reflexes, the L5 nerve root fibers travel in different peripheral nerves. For the medial hamstrings, it's a reflection of function of the tibial nerve, and for the lateral hamstrings, it's a reflection of the function of the common peroneal nerve. And so with the piriformis syndrome, we'll typically see 6 times more common than not loss or abolition of the lateral hamstring reflexes. So make it a point to test both the medial and lateral hamstring reflexes in all of your cases. Certainly test one of them, one or the other of them, to assess for the function of L5, but also to distinguish between the possibility of a tibial nerve lesion versus a common peroneal nerve lesion. Testing both reflexes give you some insight in that direction. So they'll have a reduction in the lateral hamstring reflexes, and then they'll have typical findings in the lower leg that we associate with injury or dysfunction to the common peroneal nerve, the most common of which clinically is the drop foot. And that'll be manifest as the steppage gait. Now, injury to the tibial nerve causes a different constellation of symptoms, not with drop foot, but with drop heel. Weakness of the muscles in the posterior aspect of the lower leg. And recall that the tibial nerve in the lower leg innervates all of the posterior muscles, such as the popliteus muscle, soleus muscle, the plantaris muscle, if there is one there, the gastrocnemius muscle, the tibialis posterior, flexor digitorum longus, flexor hallucis longus. All those posterior muscles, when they're weak, cause a heel drop. Not a toe drop, but a heel drop. And a heel drop manifests as a clinically completely different type of gait disorder than does the high steppage gait associated with a drop foot. I don't know if you've ever seen someone with a heel drop gait, but this is a person that has a shortened stance phase of gait due to weakness at the toe off phase of the gait cycle. And the reason they're weak at toe off is because they have loss of strength of the posterior muscles, specifically the gastrocnemius and the soleus. So there's some of the anatomy associated with piriformis syndrome. Clinically, the piriformis syndrome manifests on physical exam with a pathognomonic finding, and that is tenderness to palpation directly over the bellies of the piriformis muscle. And typically, in a hot case of piriformis syndrome, the examinee will respond to direct palpation pressure. They'll respond with a jump sign, which is an evasive action or an automatic withdrawal reflex to protect that nerve that's underneath and trapped by the piriformis muscle. So we'll go into more of the physical examination for piriformis syndrome on another video. For now, I hope this review of the anatomy of the piriformis syndrome has been helpful for you, and I look forward to being with you on future videos. This is Dr. Perry Carpenter wishing you best of success.